Thank you for those of you online and in the room. We're going to commence today's edition of Friday Noon Talk at the MPU. Our speaker today is Dr. Eric Simiele. He did his Ph.D. at University of Madison, Wisconsin, and his residency at Stanford. He's now at University of Alabama in Birmingham, and he's going to talk to us today about new methodology for delivering TBI using VMAT. Thanks, Eric. Take it away.
Awesome. Thanks, Allie. Share this. All right, cool. Yeah, so I'm happy to be here today to talk to you guys a little bit about a more modern approach to TBI, and specifically kind of what we do here and what other institutions have been adopting. I can't take full credit for this talk. I also want to highlight or mention my mentor, Dr. Natalia Kovalchuk, who is a clinical professor at Stanford. I worked under her during my residency because she initiated the VMAT TBI program there. And together we worked to kind of build it out to what it is today. And we still work together to both mutually benefit the programs at Stanford and UAB. So for this talk, we'll start talking a little bit about the historical background of TBI and like some of the older approaches of how it was accomplished. But then we'll talk a little bit about some of the more modern alternatives to TBI and how it's kind of treated in present day. And then we'll do a deep dive on one of the available modern alternatives, which is the multi-isocentric axial VMAT-based technique, going all the way from simulation through treatment. And we'll touch briefly on some of the toxicity and outcomes data that has been published. And then we'll just conclude with some final remarks. So if we take a step back and think about radiation oncology, radiation therapy as a whole, it's always been kind of a more localized therapy, even back in the days of Madame Curie, where they were taping rocks of radiums to skin lesions. It's been very localized to the disease site. Even in present day, if you have prostate cancer or localized prostate cancer or localized lung cancer, you're just irradiating that section or the involved areas of the body. However, there are other types of cancerous conditions, such as like hematologic conditions, where it may be cancers of the blood, it may be cancers of like the lymph system, where that may those cells end up circulating and going everywhere in the body. Such examples include like myeloid leukemias, AML, CML, and also lymphoblastic leukemias. And typically we want to use a more systemic approach to therapy for these patients. And when we think of systemic therapy or like more widespread diffuse treatment, we think chemotherapy for cancer. But interestingly, radiation therapy also plays a role for these types of diseases, even though you're irradiating the entire body. Another interesting aspect about hematologic conditions is for radiation therapy, we generally think of two endpoints to the therapy. It's either going to be palliation, so we're relieving symptomatic pain from the patient's disease, or it's a curative endpoint. For these conditions, like hematologic conditions, the endpoint is neither of those. It's actually transplant. So we're looking to either suppress the immune system, kind of kill off those cells, or ablate the bone marrow to remove the malignant producing cells. And once that's done, the patient would then receive like a transplant of either stem cells or bone marrow to replenish the cells that have been killed off. So radiation therapy itself, the endpoint is slightly different for these conditions as well. Now, I mentioned radiation therapy actually does play a role for hematologic conditions, and you would think that irradiating the entire body would come with significant toxicity side effects, and that is actually true. Interestingly, early studies where they were testing the role of radiation therapy and is it actually useful in these conditions, they found that the outcomes for these patients actually improved when using radiation therapy and irradiating the entire body compared to just using chemotherapy alone. And this is despite the potential for like significant severe toxicities. Now, we typically break down the overall dosing level that we're going to deliver to the patient depending on the type of disease they have. Such as for like non-malignant, like myeloid leukemias, we typically just want to suppress the immune system. So it would be accepting of stem cells. For malignant high-risk diseases such as lymphoblastic leukemias, we typically want to ablate the bone marrow. If we take a step back or think back to our lessons on radiation biology from Hall or our classes in health physics, when we say immunosuppression, we're basically trying to induce the hematopoietic effect, which typically occurs between dosing of 2 to 4 gray to the entire body. Ablation for the bone marrow, these are radiosensitive cells, so you don't need to deliver a very high dose like you typically need to for sarcomas of up to 70 gray. You can typically ablate the bone marrow somewhere between 8 to 14 gray. We are specifically targeting the marrow or the marrow-producing cells, so the bones, but for older techniques of treating the bone marrow or the entire body, we just target the entire body because it's too difficult to specifically target just the marrow. So because of this, in both these cases, we're still treating the entire body, and hence the technique had become known as total body irradiation or TBI, which is where the acronym comes from. So here we have this interesting problem where we want to go from, a localized form of therapy with radiation therapy to a widespread systemic therapy. We want to treat the entire body. So how do we actually go about achieving this? Like what technique should we use? What are reasonable goals for this type of therapy? Dosimetrically, what are realistic goals? What is realistic accuracy in terms of, dose delivery? Are there any organs at risk that we need to consider? What dosing levels do we need to spare organs at risk to? What potential toxicities do we need to be worried about? So a lot of this was outlined in a lot of the early literature on incorporation of TBI into transplant studies. And from a physics perspective, a lot of these, the technical aspects of how to do this were outlined in the American Association of Physicists in Medicine Task Group Report 29. This report was published approximately 40 years ago, and it's a very nice review of all the different methods that can be used to deliver TBI. They show some of these methods in the figure on the right, and many of these have fallen out of favor, but two of them kind of remain in common practice. That of 2 vertical beams, so basically an APPA field pair, and also 2 lateral opposed beams. Now, we want to radiate the entire body. So effectively, we're going to need a large enough field that can cover the entire body. So we're either going to need, a very wide diffuse source of radiation, or we can use our existing linear accelerators and just use the inherent divergence of the beam and place the patient far away from the radiation source. Now, going back to the overall goals of what we're realistically trying to achieve with this technique, one of the big concerns with it is we have patients, they can have relatively large separations or and AP separations, upwards of like 30 centimeters. So the question became like, what's a realistic expectation in terms of heterogeneity and the patient dose heterogeneity? So like what fluctuation from the prescription dose is realistic? And this is one of the more famous figures from TG29, where basically they're showing that there's a couple of different tricks you can exploit from the physics of how radiation is deposited in a phantom with depth. By placing, your phantom or your patient farther away from the radiation source, you're effectively minimizing the impact of inverse square fall off on the dose drop off. So by doing that, you're effectively making the dose at 10 centimeters versus, or the dose at 20 centimeters versus 10 centimeters, that delta will be smaller at, say, 300 centimeters from the radiation source versus 100 centimeters. Also, intuitively, you can just increase the energy of the photon source. So if you go from like cobalt-60 to 25 MV, the attenuation of the radiation source will be much less. So the beam will ultimately be flatter with depth. So you'll have a less dose heterogeneity. If you use the combination of these two, you can effectively really mitigate or minimize any of the heterogeneity with depth, and thus, realistically deliver a much more uniform dose to the patient. From these studies, they came up with a recommendation. It's realistic to shoot for a 10% dose variation about the prescription dose. So ideally, we want to deliver that prescription dose within plus or minus 10%. they felt that was feasible and realistic. Now, I mentioned those two techniques, the opposed laterals and APPA fields, have kind of carried into modern practice. Those are primarily the two remaining. So here are some photos of like what this setup looks like in the modern day. These are from the lymphoma radiation oncology group TBI guidelines. And you can see a patient could be positioned on a stretcher lying on their side, and the figures on the right, where they're placed far away from the radiation source. They're irradiating their entire body, and then they're placed on the other side of the room to irradiate the other side of the body. Patients that can also be standing in a specialized booth or uh, a setup, which you can see in the figure on the left of the person standing there. Here they would use supports to help them stand and also a harness in case the patient passes out. From some of the early studies of incorporating TBI into these, the therapy for these hematologic conditions, they found that the main dose limiting organ was the lungs. And the reason being is it doesn't take very much dose to the entire lung to induce radiation or radiation-induced pneumonitis. The fallout from this is if the patient gets pneumonitis, it makes it more likely the patient can encounter or acquire pneumonia, which is really bad in these patients because you've already compromised their immune system. So it can be very fatal in these patients. So the recommendation from it was we want to reduce the dose to the lungs. We want to reduce it such that we're going to reduce the incidence of pneumonitis, but also not so low that we're undercovering the patient and potentially sparing malignant cells. So what's typically ended up doing is they'll cut out seroband blocks and they'll fit them or cut them based off of radiographic projections of the lungs. And you can see that in the figure on the bottom, along the bottom. They're typically cut to reduce the radiation intensity or the dose level to 50% of the prescription. Now, the other thing to consider with this technique is the fact that when this was written 40 years ago, we didn't have modern computing resources. We didn't have modern dose calculation algorithms or anything like that. They were typically more hand calculation, point-based calculations. And a lot of that relied upon assuming the patient was basically a uniform block of water. And if the patient has uniform thickness across their entire body, great. It makes it very easy to perform the calculation and assume the dose is going to be delivered, homogeneously throughout their entire body from head to foot. But obviously, people are not uniform thickness across their body. When the calculations are done to actually determine how many monitor units or how much radiation to deliver the prescription dose, they typically pick, or they'll pick a specific point along the patient to run this calculation. And usually it's the umbilicus or the belly button. They'll use the distance from the radiation source to that point, and then also the patient thickness at that point. And then they'll add in a bunch of different calculations for the separation of the patient at that depth, the scatter corrections, etc. However, we run this calculation and we're able to deliver the dose at the level of the umbilicus. But if you go down 20, 30 cm down to the mid-thigh or the knees, the separation there, or the patient separation, is substantially less than at the level of the umbilicus. So you may end up way overdosing the legs at that region. So to combat this, you typically create a compensator effectively to compensate for the fact that the patient is not uniform thickness. And you can see a figure what that can kind of look like in the figure in the middle, where you would tape strips of lead or variable amounts of strips of lead onto an accessory tray, and you would plug that accessory tray into the head of the linear accelerator, and it would just compensate for the fact that the patient is not uniform thickness. So TBI itself, the first studies of incorporating this date back almost 70 years ago. AAPM TG29 was published almost 40 years ago, and it obviously leverages none of the advances that have happened in the field since that time. And because of this, working groups like such as AAPM is working to kind of update this to incorporate more of the advances that have happened in the field since then. Some of the problems with these older techniques is, as you can imagine, you need to place the patient far enough from the radiation source to cover the entire patient. So you're going to need a larger linear accelerator vault than like a standard vault that would just fit the linear accelerator because you need to place the patient far away. You will need dedicated TBI equipment, such as like a dedicated stretcher or a platform where the patient can stand and have support harnesses, et cetera. You need the ability for your clinic to be able to cut cerebellum blocks based on the projection of the lung volume. You would also need what's called a beam spoiler, which this is effectively 5 to 10 millimeters of lucite or acrylic, and it's placed in front of the patient. The reason being is the majority of the skin dose from photon-based treatments comes from what we call electron contamination in the head at the accelerator. When you place the patient far away from the radiation source, a lot of that electrons that are generated have an opportunity to scatter away or be attenuated. So this is the way to basically regenerate that electron contamination to make sure the skin is fully getting dosed. Now, with the modern advances in the field since this time, there have been some publications coming out starting to question the accuracy of these older techniques. It's one of those things where a lot of the dosimetry for this was when these programs are commissioned, they're commissioned based on water phantoms or uniform phantoms. But when you do the calculations on a patient, you're typically just using points along the patient midline. And that's all that ends up getting reported, even when on clinical trials. So you're missing a lot of that dosing information that we have available now. This becomes particularly problematic on certain newer trials that are coming out, such as scleroderma trials. So that of the SCOT, the STAT2 trials, which have very strict requirements on the mean dose levels that can be delivered to the lungs and the kidney. They specify they have to be 25% of the prescription dose or less, which is incredibly challenging to do. And particularly some of these studies, when trying to commission these programs, have made measurements and showing that like our calculations are showing this is what the dose should be, but what we're measuring is not in line with this. It's like 15 or so percent off. So there's a bit of a discrepancy there. Next is one of the issues is organ at risk sparing. It's pretty easy to spare the lungs because there's quite a bit of radiographic contrast in the lungs versus other parts in the body. But if you say wanted to spare the kidneys, well, radiologically, the kidneys look very similar to other parts of the body or other parts of tissue. So it's much harder to localize those. And I believe even on these trials, they recommend using ultrasound to localize where the kidneys are and to use it for block placement, which is incredibly tough to do. Also, going back to the issue of 2D dosimetry, there's issues of dose reporting. I remember when we run these calculations, you're typically just reporting the dose at 8 to 12 points along the patient, and that's it. Whereas we have access to so much more information now where we can run full 3D dose calculations on voxelized phantoms, and we can store and record all of that data. Lastly, I mentioned initially about the toxicity rates with this technique. They can be relatively high, where any grade of pneumonitis can be upwards of 30 to 40% for these patients, and also nephrotoxicity or renal toxicity can be relatively high as well. It can be upwards of, there's been some studies that report it at a level of 25% and upwards of 75% for those undergoing myeloablative treatment regimens, so upwards of like 12 gray prescription dose. So let's talk about some of the modern alternatives that have been introduced. And these, when I say modern, I basically mean incorporation of the advances in the field that have happened since then. So such that use accurate dose calculations on CT scans that incorporate heterogeneity calculations, that are doing full 3D dose calculations, utilize intensity modulation, accurate image guidance for patient setup, and also have the ability for like more increased patient comfort where they can, stay positioned or laying on the treatment couch. In general, there's three main methods that are available to do this. The oldest is that of helical tomotherapy, which is introduced in the early 2000s by UW-Madison. There's also a single isocenter sagittal arc composed of 20 some odd static beams with the patient on the floor, or it can just be a partial VMAT arc. And the last is a multi-isocentric axial VMAT-based technique, which has also been implemented by a lot of institutions. Now, when going to these more modern alternatives, you can obviously imagine there's going to be significant challenges in implementing this, particularly when we're going from like a technique or a treatment technique that's just does 2D dosimetry, where you're calculating MUs based in an Excel sheet for a patient based on how far the patient is from the radiation source, their thickness, et cetera, to actually doing a full 3D dose calculation on a CT phantom. There's a huge increase or an exponential increase in the complexity. It's also a huge increase in the planning of physics resources because the the dosimetrists required for planning this technique, it may suck up several days of their time. It may require a few hours of physics checking it and doing QA on it, whereas previously we really didn't do QA on these types of patient or like patient-specific QA, et cetera. There's also the interesting challenge of, because this is so new and these techniques are still emerging and data is still emerging, there really isn't a lot of consensus guidance documents on how to do this. Something as simple as, how do you actually define the target for this? How do you, what organs at risk should be considered? What dose should they be spared to, or like what dose limit should be applied? How should image guidance be applied? What level of target coverage is acceptable? What about the lung dose rate? Is that, I mentioned previously, that's kind of a big concern in conventional TBI, where they're shooting to limit the dose rate to the lung to less than 20 centigrade per minute. In the field of intensity modulation, well, there's a lot more nuance that needs to go into like how that is interpreted. There's also the question of circulating cancer or lymph cells, where with these more modern alternatives, you're not irradiating the entire body simultaneously. You're irradiating chunks of it. So there's a real question of, well, if you're only radiating sections of the body at a time, would it be possible that, uh, a potentially malignant cell may be evading the radiation treatment field and potentially go untreated? So now I thought we could kind of do a deep dive on the last modern technique that I mentioned. This is the technique we use at UAB, and it's also used at Stanford. It's used at NYU, McGill, BC Cancer Center, Tom Baker Cancer Center in Calgary. Part of the reason a lot of places like this technique is that it fits in fairly nicely with the existing VMAT workflow. It doesn't require special setup or stuff like this. And a lot of the equipment is readily accessible to a lot of clinics. So starting with simulation, like how do we actually simulate these patients? You obviously will want a full body CT scan, and institutions will typically use a slice thickness in the range of 3 to 5 millimeters. Obviously, because we want to scan the entire body and treat the entire body, we want to immobilize the entire body. This can be done using commercial products such as the Civco VacLock body bag, where they make bags that are like 180 and 210 centimeters or something like this. You can also use Smither Medical Products Alpha Cradle, which is what we use at UAB, and you can cut those to size for each individual patient. You can use the Civco foot and knee fix to help immobilize the knees and the feet to make it a little bit more comfortable for the patient. Ideally, you want to place the arms nice and tight and close to the body and minimize air gaps between the body and the arms as much as possible. You can also use a thermoplastic mask on the head to try and immobilize the head and the shoulders. Now, in terms of BB marks for studying the user origin, this varies a little bit across institutions. At UAB, we choose to place the BBs in the center of the head on the mask. Stanford chooses to place them approximately 6 centimeters superior to the umbilicus. Other institutions will have other practices, and they may elect to add additional marks to mark what they call a match line, which is basically describing the transition between VMAT and APPA fields, or the upper part of the treatment and the lower part of the treatment. This CT scan you see here is actually a patient that we treated a few weeks ago here at UAB. He was probably our tallest patient we treated. I believe he was just under 205 centimeters, so he was really quite tall. And we were able to treat him successfully with no issues. So some of the issues you may run into with this type of technique, there's two different facets of this. First, you may end up with limitations in terms of treatment. So when you're trying to treat the entire body of a patient, you have to consider the longitudinal travel extent of the couch. So you can only push the couch so far before you're going to end up running it into the LINAC or the linear accelerator. We generally use a cutoff of patient height of less than 116 centimeters to indicate if they're shorter than that, we can treat them entirely in the head first supine position. And we can treat them entirely with VMAT fields and VMAT isocenters. And we'll typically use 3 isocenters to do this. If the patient is taller than this, it's likely the couch longitudinal extent will, or the couch will likely hit the gantry before you're able to treat the entire body or particularly the legs. So we'll have to break the treatment into 2 sections where we'll treat the upper portion of the body in the head first supine position using VMAT arcs, and then we'll typically treat the lower part of the body with APPA fields. We use APPA with field and field modulation and in the legs, particularly because there's no organs at risk that we really care about down there. We just need to control hotspots and ensure there's coverage. So we don't really need that much modulation to achieve that. Now, the other thing to consider is for simulation. Now, if you have a CT scanner, like a PET CT scanner, you may be able to acquire a CT scan of the entire patient body just lying in the head first supine position, which is awesome. It makes life so much easier. If you don't have that, if you don't have like a PET CT, it's likely the longitudinal travel extent of your CT couch will not permit you to scan and the entire patient body. So you end up in a situation where you have to scan part of the patient body in the head first supine position, have the patient come out of the CT scanner, turn around, and then scan again in the feet first supine position. So you end up with 2 separate scans. In that case, you can plan the VMAT portion of their treatment on the head first supine scan, and then you can also plan the APPA fields on the feet first supine CT scan. However, planning on 2 separate scans, while doable, and we've done that for a long time here at UAB, it makes it really quite cumbersome to try and evaluate these plans or like actually treat them because you need separate user origins and things like that, or separate shift points. Now, one of the common themes, or one of the common things that can be done to combat this is you can take the 2 CT scans that are required and concatenate them or stitch them together and use the combined CT scan for planning. There are some commercial softwares out there that allow for this, such as MIM, Variant Velocity, or other institutions elect to write their own custom in-house software, which I'll talk about in a second. Now, I mentioned like treating the patient in multiple treatment orientations, both head first supine and feet first supine. As you can imagine, when you're treating them, it's a bit cumbersome to treat all the isocenters in the head first supine position, have the patient, come out of the linear accelerator, get off the table, and have them spin around, and then reset them up in the feet first supine position. To try and streamline this, some institutions have developed their own custom in-house rotational couch tops, such as those at UT Southwestern with the Lazy Susan, or what's shown in the top right for what was developed at Stanford, what they call a spinning Manny. Here, the patient would be simulated on this couch, and then it just streamlines the transition from head first supine to feet first supine. They're able to treat the head first supine isocenters or the VMAT isocenters. Once that's done, they can just pull the couch away from the linear accelerator, unlock the couch top, spin them around, spin the patient around. They don't have to get up, and then just relock it down, and then just resend the couch back to the treatment coordinates. So it really streamlines treatment and helps the therapy out. This has recently become, or products have become recently commercially available in the United States. I believe it's in North America in general from Orfit, and I believe there's another company out of California that sells them. And that's kind of what's shown in the bottom right. They're available for purchase. Now, coming back to concatenation software, it's not uncommon for clinics to write their own custom in-house ones if they don't have these commercial tools available. I believe UT Southwestern built an engine in Python where they just export the CT scans, the 2 CT scans out, and it'll just concatenate them together and rewrite it back to their treatment planning system. At UAB, we recently implemented our own, which is something that I developed here, which allows, once the CTs are concatenated together, which is what's shown in these images, their dosimetrist is allowed to review it and make sure it looks acceptable. And once the review is completed, they can just directly push it back to ARIA. And we've also linked it up to our own in-house auto contouring solution, which will streamline the contouring process. Speaking of contouring, how do we actually define the target in OARs for this treatment technique? Well, historically, we said we just want to treat the entire body, everything to the prescription dose. Well, in the era of like intensity modulation and VMAT, if you want to treat the entire body, including all the way up to the skin, to the prescription dose, that's really difficult to do with VMAT, and you will effectively need to cover the patient with bolus, anywhere from like 3 to 5 milliliters, to ensure you're getting the full dose at the surface of the skin, which really isn't feasible to cover the entire patient in a few millimeters of bolus. So because of this, it's common to create the actual target as the body with an internal margin. And this margin, some institutions don't use any, but many of them will use between 3 to 5 millimeters of an internal margin. And that's because the skin typically isn't involved in the patient's disease or anything like that. So it's not necessary to give the exact prescription dose to the skin. This target, or subtract the body with the internal margin, is what we define as PTV body. So it's basically the target we're trying to dose to that prescription dose. We'll split it into 2 different targets to denote the regions that will be covered by the VMAT portion and the APPA portion. And we designate these respectively as PTV upper and lower. And you could see how we actually define these targets. It's common to actually crop away the organs that we care about or that we're interested in sparing from these targets. So we'll typically crop away, at a minimum, the lungs, the kidneys, and the lenses from these targets. You can see how we define that in these two tables here, where we break it down based on what the overall treatment intent is for this patient. Where for myeloablative, we're looking to actually ablate the bone marrow, we really only want to spare these organs. For reduced intensity conditioning or non-myeloablative regimens, where we're treating like myeloid leukemias, there's a lot of organs that really aren't involved with that disease. So we're able to additionally spare, the thyroid, the brains, the gonads to try and preserve fertility function, etc. And we typically will use variable margins when cropping these organs at risk from the target. Now, in terms of like setting up the plans and placing isocenters, we'll typically, for the VMAT portion, use 3 to 4 isocenters in the head for supine position. And you can see examples of what that looks like in the figures on the right. And they'll typically be placed along patient midline, going from superior to inferior. Each of these isocenters will contain 3 to 4 or 2 to 4 VMAT arcs. And we want to maintain at least 3 centimeters of overlap in these field junctions and try and ensure smooth dose gradients between the fields in each, or the adjacent isocenters. We also have a special consideration where we want to limit the overlap of the head and abdomen fields, or the fields in those isocenters, with the lungs, particularly when we're considering dose rate to the lungs, which I'll talk a little bit more about in a second. For the APPA fields, we'll typically use 1 to 3 isocenters in the feet for supine orientation with a 90-degree collimator rotation, and we'll use field-and-field modulation. Some institutions actually elect to use all VMAT instead of using APPA because they find it fits in better with their workflow, such as BC Cancer Center, and I believe also Tom Baker Cancer Center in Calgary has also indicated interest in that. Now, in terms of actually setting up these plans or preparing to optimize, there's a certain order that it needs to be done in. So first, you need to plan the APPA fields first. It doesn't have to be necessarily perfect. It doesn't have to be the final product, but it has to be something. It has to be something that the optimizer can match or try and match those dose gradients. So you do that by setting the APPA plans or the sum of those plans as a base dose for the VMAT optimization. You want to ensure that, well, if your treatment planning system allows it or has the feature to create dose gradients or smooth dose gradients between fields and adjacent isocenters, you turn it on. In Eclipse, which is what we have, the feature is called auto feathering, and it just creates the smooth dose gradients automatically for you during optimization. We want to limit the dose rate for fields intercepting the lungs to 200 MU per minute. This is what's used at Stanford and also at UAB. I had mentioned back to what I said previously about historically, we want to limit the dose rate to the lungs to less than 20 centigrade per minute. Well, how you actually implement a more modern technique depends on how you interpret that statement. When we say the dose rate to the lung is less than 20 centigrade per minute, do we mean the instantaneous dose rate to any section of the lung? Do we mean the overall mean dose rate to the lungs, to the entire lung? If you interpret it as just the instantaneous dose rate to any small section of lung, you're going to end up having to use a very low dose rate field. In fact, that's when the program was started here at UAB 5 or so years ago. They used a special beam module or to achieve a dose rate of 50 MU per minute. I believe at UT Southwestern, they still use 40 or 50 MU per minute for the fields treating the lungs. We are at Stanford, and also how we interpret it now at UAB, is we mean the mean dose to the entire lungs over the course of all the fields treating it, or the entire time it takes to deliver the dose to the lungs, which you could calculate out for how many fields you're treating the lungs, what's the overall mean dose to the lungs, and then you can just back calculate what dose rate do I need to adjust the beams to actually achieve this, or this 20 centigrade per minute limit. Ideally, you want to template all of your clinical goals, optimization constraints, optimization structures, et cetera, as much as possible, because it really doesn't change from patient to patient, and you can waste a lot of time, manually entering these for every single patient. So this is kind of what I'm talking about for our planning objectives, and which our optimization constraints are kind of derived from. So in terms of target coverage, we're looking at the dose at 90% of the PTV body. We ideally want it to be 100% of the prescription dose, but we'll accept 95%. And we want to keep the maximum dose in the PTV to under 130%. It's quite a bit hotter than what's conventionally done, but it's not unrealistic in the era of VMAT. We place an additional constraint on the volume of the PTV receiving 110% of the prescription dose to less than 5%. We also look to aggressively spare the lungs and what we call the lungs eval volume, which is the lungs contracted by a CM. So we look to spare that to less than 60-ish% and 40% of the dose, respectively. And you can see for all the other organs we have listed here what our general goals are for these organs. These goals that we use are actually in line with the recently initiated COG ASCT 2031 multi-institutional trial, which is a COG transplant-driven trial where more or modern TBI is actually included as a standard of care or option for these patients that are going to undergo transplant. And these are the planning goals that are actually recommended in that trial, which in the curation of this, or the generation of it, Natalia and I worked with the lead author on that trial and coming up with these constraints. So as I mentioned, a lot of the objectives and how these patients are set up and how the targets are derived, they don't really change from patient to patient. So obviously you can template a lot of this, which is great, but you can also automate a lot of it, particularly if you can automate it through like a scripting API or something within your treatment planning system, even better. So this is something Natalia and I had worked on as one of my residency projects, where we're basically, you'd start with like the structure set of a patient and a CT scan. You can select a prescription template, and you can adjust what kind of structures you want to spare or crop away from the target. And it would just go ahead and do that for you and generate that. Once it's done that, it knows it's going to need however many isocenters, say 3 isocenters for this patient to cover the entire patient body. And you can adjust then how many beams you want to use for each isocenter. At that point, when you actually tell it to generate the plan, it's going to do that and figure out where exactly to place the isocenters and how to orient the beams to best cover the patient. And based on what you previously done, it would then just suggest optimization constraints that it recommends for this patient, which you can fully adjust. So from this script alone, when we were doing this process manually, it would take a few hours to like contour everything and create all the optimization structures and set up the plan, orient the beams, et cetera, et cetera. This script was able to do that in under 30 seconds. So it was a huge efficiency improvement, making this much more feasible. The other side of it was automating the optimization process. The calculation volume for these plans can be really quite large. So it can really suck up a lot of computing resources and require a lot of babysitting from dosimetrists where they're watching the optimizer run, but it's not really advancing that much. So we developed a second tool that would kind of pick up where the first one left off. And its sole purpose is just running successive optimizations and just playing with the optimization constraints, trying to come up with an optimal plan. We would typically just launch this at the end of the day. It would run for several hours overnight, and then the dosimetrists would come back in the morning for a plan ready to review that they can then make final tweaks to, or they can just say it's good as is. I'll send it to the physician for review. Now, when we think about TBI, at least in the conventional sense, we think about, it's a uniform dose, the prescription dose covering the entire body. But obviously that's not going to be the case in the era of VMAT. It's going to vary quite a bit more. So what I wanted to show here is what actually a dose distribution looks like on a real patient. So this is that 200 centimeter patient that we treated recently. And for context, the prescription dose is the yellow. So it's 200 centigray, 95% is 190 centigray, 90 is 180, and 120% is 240. So this is just scrolling from inferior to superior. So we're in the APPA portion of the field, so it's very uniform. And it'll be very apparent once we switch to the VMAT portion, and this will become far more heterogeneous in the dose distribution, which we just transitioned to now. So when we're evaluating these, we absolutely want 90% of the dose to cover 100% of the target. That is kind of critical. But ideally, we want, again, 90% or the dose at 90% to cover 100 or to be equal to the prescription dose. And you can see in scrolling through this, we're able to very nicely carve away dose from the lungs, the kidneys. Here you'll see for the thyroid, and then also from the brain. And this is our in-house tool that we use for dosimetry, plan quality checks to make sure it's meeting all of our practice guidelines or constraint guidelines that we use at UAB. And it's basically all those planning objectives that I showed earlier, where you can see it's, because everything is green, we're meeting everything where we're just exceeding a dose on some priority 2 constraints. So they're not going to impede treatment. So here's also what another example what a dose distribution looks like. This is for a pediatric patient where the plan was normalized such that the dose of 90% is equal to the prescription. And the D max for this patient was 100, just under 115%. So very much in the realm of what's been done conventionally. We were also able to spare the lungs to just under 42%, the kidneys to just under 65%, and the gonads to 30% of the prescription dose to try and preserve fertility in this patient. We're also able to do some more special cases or special things with using this more modern TBI treatment. This patient was a 9-year-old with ALL who had been treated previously to 60 gray in the brain 2 years prior to TBI. We didn't want to give another full 12 gray of dose to that same irradiated region for fear of potential brain toxicity. So we were able to register their previous planning scan and use that dose distribution from that prior treatment as an avoidance volume. So we were able to actually spare that region to, I believe, the mean dose much under 50% of the prescription. This was an 18-year-old boy with ALL who was actually treated to a myeloablative dose of 12 gray and 6 fractions. This patient had severe portal hypertension, and the transplant physician was actually very worried about liver toxicity to the point where they're recommending against TBI treatment if it was done the conventional way. We were able to treat them with VMAT TBI and actually able to aggressively spare the liver to just under 55% of the prescription dose. And this patient didn't encounter any liver toxicity side effects from this treatment because we were able to spare it. Now, what is this treatment or dosimetrically, what does it look like compared to what's done or conventional treatment? And that's what you can kind of see here. This is from a recent publication in Frontiers in Oncology. And this was a VMAT treatment where the patient was, or a conventional TBI treatment was recreated on the same patient data set using a validated beam model in the treatment planning system. And what they found is that the conformity of the dose got much better to the target, but they were also able to much more aggressively spare a lot of the organs at risk, even much more so than what was previously thought with conventional TBI, particularly with the lungs. This is for like a full myeloablative dose, and it only gets better when you go to like reduced intensity conditioning, where you can easily spare many more organs at risk with VMAT, which really isn't possible with conventional TBI, or it's much more cumbersome to do. So talking a little bit about QA, now that we created a plan, how do we actually QA it? Well, for patient-specific QA, there's a couple of different options. You can use detector arrays, such as like the Delta 4 or the ARC-check, to perform measurements for each isocenter. Popular choice, because it's very convenient and easy to do, especially when you have a lot of plans, is EPID dosimetry or portal dosimetry. This is currently what we do at UAB, and we typically evaluate using gamma criteria 3% 2 millimeters, and we look for gamma passing rate greater than 90% for each of the VMAT plans. This is actually all the fields for the chest isocenter of that 200 centimeter patient that I showed previously. And you can see how we're carving the dose away from the lungs in these in the composite field, which is kind of cool to see. Now, if the portal dosimetry at the gamma passing rate is less than 90%, we'll typically request an additional ion chamber measurement just to assess the absolute dose of the plan, just to make sure it's consistent with what was planned. In terms of independent dose calculation, you can use basically any commercial software available, such as Variant Mobius, RadCalc, Sun Nuclear, SunCheck, etc. Typically, for these, many of them don't accept plan sums, so you would typically need to export each plan individually or each isocenter individually. And in that case, you're not really looking at DVH constraints for like target coverage. You're typically looking more at like a gamma analysis of the dose within that field. We typically evaluate the gamma criteria of 3% 3 millimeters and look for a gamma passing rate greater than 95%. If it's not meeting that, we would also request an ion chamber measurement during PSQA. In terms of how do you actually commission this, because this is really a much more complicated technique than what has been historically done. Well, you have to think about what are the things you would be worried about in treating this technique. The biggest ones I can think of are primarily, reproducibility and positioning the patient and treating them, the dose between field junctions and adjacent isocenters, looking at the match line reproducibility. So like that transition between VMAT and APPA, what is the dose reproducibility there? And also what would be like the surface dose, the patient making sure that's accurately represented in the treatment planning system. Because the VMAT TBI is included as a potential treatment option on the COG ASCT 2031 trial that's overseen by IROC, you can actually request a radiation phantom from them because they do the credentialing. You have to pass the credentialing to get on that trial. So you can request the phantoms from them and irradiate them how you think you would actually set up the patient, and then they would tell you if the dose of what you're predicting is actually accurate. You can also download some example data sets that IROC has and create practice plans. You can download freely available auto planning scripts to help you get started and get you much closer to the planning consistency of what's expected. You can also test the robustness of your plans by like shifting isocenters around to come up with what are available shifts, like residual shifts that can be applied while imaging the patient. Now, in terms of treatment, there's quite a bit of variability in terms of what image guidance is used to set up these patients. I've shown on the right here 2 examples of like what can be done. Like Stanford, they were more concerned with treating or aligning the lungs because that's the most critical OAR for this type of treatment. So they would typically do a KV-KV orthogonal pair to get the ribs relatively close, and then perform a cone beam CT to then fine-tune the alignment of the lungs. They'll then shift to the head isocenter and just apply an MV AP port just to align the laterality of the patient, and then shift down to the pedalus isocenter, perform an MV port, and then they'll spin the patient around and then perform MV ports for the remaining isocenters. After they perform imaging of each of these isocenters, they would then just treat. At UAB, we just go from superior to inferior for each of the isocenters and just perform KV orthogonal pairs and apply shifts and then treat for each. It's critical not to apply pitch, roll, or yaw correction, so no 6 degrees of freedom corrections when aligning these patients, because you may align it looks great at the head isocenter, but then that alignment that you just did may cause the patient to be quite a bit off, or it may mask like some misalignment that may really create a problem down the road at subsequent isocenters. You ideally want to not implement or not use residual corrections or shift corrections in the shift direction. So you want to preserve as much as possible planned dosimetric shifts. A common question I get asked about this is like, what's the delivery time look like for this? Based on Stanford's first 35 patients, I've shown the time range here. On average, they'll treat just under 48 minutes, which is comparable to what the treatment time was for conventional technique. However, their patient population is predominantly pediatric with a median age of 13 years. At UAB, our treatment times are consistently between 50 and 70 minutes, where our patient population is predominantly adults at 50 years. So even then, treatment slots are typically an hour or just over an hour. The institutional range that's reported in the literature can range from about 35 minutes to an hour or just 2 hours. And that's kind of highlighted in this table where we scrape together all the available data that's published in the literature on this technique, where we listed like key attributes about what treatment planning system they use, how do they define the target, what organs at risk do they spare, what's the treatment planning time, what's the treatment time, and how do they what's the overall imaging technique they use. And I believe I'll probably make these slides available to you guys so you can look at this table in detail later. Now, talking a little bit about toxicities, well, the data is still emerging. This is still a relatively new technique. There's been sub-publications out of Stanford and UT Southwestern on like 6-year experience, 5-year experience on this and what outcomes they've encountered. The general trends that they've seen is like there's no real significant differences in 1-year overall and progression-free survival between VMAT and conventional TBI. And you can see Kaplan-Meier plots of that on the right. Interestingly, modern TBI or IMRT TBI shows very low incidence rates of radiopneumonitis or radiation-induced pneumonitis with less than 3% incidence rate compared to what I said previously. With conventional TBI, the incidence rate could be upwards of 30% or more. As I mentioned previously, conventional TBI can have renal toxicity insufficiency of up to 25%. It can go up even higher for myeloablative doses. The data is a lot more varied for VMAT TBI or modern TBI for renal toxicity because it really depends on going back to this issue of consensus guidelines of how to do this technique. Like, should the kidneys be spared? What dose level should they be spared to, etc. When they're aggressively spared, the incidence rates of this renal toxicity are really quite low. When they're not spared aggressively at all, like their mean dose is allowed to go up to the prescription or 90% of the prescription, the incidence rate could be much higher, of upwards of 30+%. Another side effect that's really gained a lot more attention is that of oral mucositis, where the grade 3+ oral mucositis incident rate, even with modern TBI, can be not reported in the 30-ish%, but it can go upwards of 100 towards 100%, depending on which studies are looked at. There was a study out of Moffitt where they encountered a few grade 5 toxicities from oral mucositis, meaning the patient died from this side effect. And to try and combat this, they actually tried to crop or remove the oral cavity from the target. Well, they interestingly found they didn't encounter any more grade 5 toxicities, but they found that the incidence rate of their oral mucositis really didn't decrease. So it likely means that this toxicity is not only due to radiation, it's also likely caused by concomitant chemotherapy and also potential graft versus host prophylaxis. So with that, I've kind of given you a whirlwind of information on VMAT TBI and modern TBI. I'd like to just kind of conclude with saying like modern TBI, it's slowly starting to replace older conventional techniques, where VMAT TBI is one of the more popular methods because a lot of clinics already have the available equipment and it fits in nicely with their existing workflows. It offers, or VMAT TBI or largely modern TBI allows for the possibility of, unique organ sparing, such as lungs, kidneys, gonads, brain with ease. You're able to use like accurate dose calculation methods and image guidance. You can, treat the patient lying on the couch so they don't have to stand, and you can treat patients in a regular size Linac vault. You don't need an extended vault size. For any of the techniques that are utilized, planning automation for these techniques is really critical. We found that like when we were starting to implement this technique, doing it manually, the planning time could be several days. In fact, before I started making changes here at UAB, our sim to treat timeline was a minimum of 3 weeks here for these because these took so long to put together. So any amount of planning automation you can do will be immensely helpful. We've been able to like reduce it here down to, I believe 7 days is our minimum now. At Stanford, they're able to turn around in 5 days. There are some freely available tools or open source tools, which of course I'll do a shameless plug for my own, which is the top one listed, which was developed again out of Stanford and has been far more mature than the videos that I showed previously. There's also a tool that was produced by Varian called the TXI Helper. It automates portions of this type of treatment, but it only does certain aspects like CT concatenation, or it might set up the beams for you, but it doesn't do like actual optimization on its own. They also partner with NYU to create a closed source solution where they just distribute the executable for their script. So it just plans it according to how NYU plans these TBI cases. So with that, I'd like to just conclude and say thank you very much for everyone who attended and listened, and I'd be more than happy to take any questions at this time.
Thank you so much, Eric. I'm going to see if I can figure out how to flip the camera around. Or maybe I'll just leave it on the room, actually. Can you see the room?
Mm-hmm.
Do we have any questions in the room for Eric? Dan?
I missed this detail, I apologize. You said that your rates of phenotoxicity and pneumonitis went down significantly when you used the VMAT. If you aggressively spare those organs. Did you find any differences in terms of like recurrence or the success of the treatment itself? Like, did it compromise it in any way?
No, I mean that's the interesting part. Like the incidence of like relapse or anything like that, or the incidence of graft versus host disease or anything, they were not significantly different from conventional TBI, indicating that these organs are either not involved, so it's okay to more aggressively spare them, or that even with sparing them, we may be missing such malignant cells or something like that, but it's not enough to compromise the actual effectiveness of the treatment. So because of this, the general data is showing like it's okay to go for this, or to really go for it in terms of sparing these organs.
I have a couple questions for you also. When you started at UAB, who was the main driver of this change to this technique? Did it come from clinicians or physics or partnered, or how did that come about?
It was from a physicist. So for, I mean, for those of you working clinically and encountered some form of conventional TBI at some point, more or less you'll find like it's really at odds with what is available like in our modern setting where we have like a modern treatment planning system. We have very nice curation of our data. It's stored very nicely, organized very nicely. For these conventional treatments in TBI, you're typically referencing or making calculations off an Excel spreadsheet. You're just entering, you know, patient thickness at different points in their body. You're reporting or you're entering in like how far away the patient is from, you know, whatever, like from the radiation source. So, and a lot of times you also have like hard coded in like scatter corrections, attenuation corrections for like compensator thicknesses or like strips of lead. If that data is not really well organized, if you can't really reference, or there's not a nice lineage of like tracing back to commissioning reports, you may end up with these Excel sheets that have just hard-coded numbers in where it's just a number with like 10 decimals after it, and there's no traceability of where that came from. So that kind of was the issue here from like one of the former physicists when they took over the program. It eventually got to the point like he's trying to trace back where all these numbers or these corrections were in this spreadsheet, and he's like, I can't find where any of these are. The physicist who initially set this up has left. No one knows where they are. I can't sign any more of these plans. So that was kind of the initial catalyst that set in motion this transition to VMAT. And we also had a faculty member from UT Southwestern who had experience in it and could help with that transition. So uh, that's kind of the backstory here. At Stanford, it's also, I mean, just to drone on a little bit more, at Stanford, that the initial catalyst was trying to initiate or join the scleroderma trial, so the STAT trial, where they have very, very strict requirements for mean dose delivered to the kidneys, which is incredibly hard to do with a conventional TBI, particularly in cutting and placing the blocks, because there's no radiographic contrast for the kidney. So you have to use ultrasound to place them. So it just becomes a very cumbersome, difficult treatment technique, which there's a high, well, propensity for error. So that kind of initially drove them to change to VMAT or adopt VMAT.
Thanks. And my follow-up question to that is how did you, like, because you mentioned in your talk, because this is quite different from traditional methods of delivering TBI, we've got a very significant change in the dose rate and in the question of circulation of the blood while we're delivering the treatment. So how did the clinicians, like, how did they approach that question? You did show like some follow-up data from like a year or two out showing that the Kaplan-Meier shows there's no difference in the treatment, but how did they address that as a clinician physics group?
Yeah, so it was kind of addressed a little bit in tandem between the two. So it's not something that's really apparently obvious when first adopting this technique or when it was first adopted, because we have always historically just irradiated the entire body simultaneously. So what initially convinced physicians to like kind of, you know, accept it and continue treating with this technique was based off like initial analytical modeling of like blood flow kinematics throughout the body, showing that like for average blood flow or circulation rates, that the dose received by any particular cell as its journey through the body should be acceptable. So it's based off initial modeling of that, which is relatively rudimentary. There's a recent study, I believe, published by, I believe the name was Malloy, where they did like a more comprehensive assessment or modeling of it, showing or finding similar results. But it's one of those things where I think they did it initially as like based on a trial or a clinical trial, and they believed or they had reason to believe that it would be effective, but they couldn't really prove it until they had outcome data to support it. In terms of lung dose rate, it's also a little bit of a similar story. I mentioned, depending on how you interpret that original constraint from the the recommendations of limiting the dose rate to 20 centigrade per minute, it really influences how you address or approach this technique. Oh yeah, I do have this slide. This is a slide we like to show and we talk about quite a bit. So we typically use the blanket recommendation of less than 20 centigrade per minute, less than 20 centigrade per minute. But as we progress in this modern area, it becomes very important to like actually dissect down what does that actually mean. And it's not as simple as just keep the dose rate under this amount. And upon reviewing these studies, like it came back a lot more to, it seems to be an interplay between the overall mean dose to the lungs and the dose rate to that entire lung. So it depends on both of them. So if you aggressively spare the lung to like, less than say 6 gray or less than 50% of the dose, you can use a very high dose rate and the likelihood that they'll develop pneumonitis is relatively low. Or for instance, if you deliver, a higher dose, you can go upwards of like just under 8 gray and use a lower dose rate. It also mitigates the risk of incurring pneumonitis. And there's been a bunch of studies that kind of listed in the table here showing the actual findings and the reasoning behind this data is actually quite a bit more varied than you would think. So I believe they initially chose that number from conventional techniques. It's carried over into modern recommendations of 20 centigrade per minute to be, conservative. But another thing to point to is tomotherapy doesn't have an option to modulate the dose rate or adjust the dose rate on a beam. It's fixed at 850 centigrade per minute or ME per minute. And they've been, the modality has been treating modern TBI the longest, and their outcomes data has not shown an increased risk of radiation-induced pneumonitis compared to conventional techniques. So.
Great, thanks. Can I take questions from online or no? Does anybody online have anything they'd like to chime in or ask about? You can put it in the chat or unmute yourself, I guess. All right, with that then I guess, let's thank Eric one more time for his great talk on TBI. Thank you so much.
Awesome. Thank you.
Thank you.